Guess we'll start. Well, thank you everybody for joining us today. Today we have the pleasure of having Dr. Elise Ann Scoggins and Dominique Watt in presenting their work on improving operating room efficiency through reducing first start delays. Dr. Scoggins is a Senior Director of Strategic Programs and Ops Planning for Interventional Platform, Imagining in Pharmacy, where she oversees the program management, performance improvement, and shared spaces teams. She's responsible for large and complex projects and integrating process and performance improvement to address complex process breakdowns within departments. Before joining Interventional Platform, Elise worked in facilities, services, and planning as a senior business manager, supporting hospital and clinic activations, property services, and the labor budget for 500P. She earned her bachelor degrees in health administration and policy from Creighton University in Omaha, Nebraska, and her master's of health administration from St. Louis University. After she earned her degree, she stayed in the Midwest for 7 years, working in strategic planning at SSM Health, Catholic Systems in 4 states, and BJC, one of America's largest integrated academic healthcare systems in the United States. Working in strategic planning exposed her numerous aspects of healthcare, from service line expansion, new hospital and outpatient center planning, developing patient classification process to track INP, ops, OP volumes, volume growth or market projections, launching new application-based products to track physician referrals. And her colleague, Dominique Watt, began her nursing career in 2007 and joined Stanford Healthcare in 2010. She has evolved into a leadership role since 2013, focusing on clinical operations, process improvement, education, and clinical effectiveness. An energetic and creative healthcare leader, Dominique is dedicated to delivering high-quality patient care and fostering a compassionate environment for both patients and staff. She excels in team development and effective communication, ensuring that patient-centered care and employee engagement remain central to her approach. Outside of work, Dominique enjoys traveling, walking, watching sports, and spending time with her family. Welcome, everybody, and take it away, Elise and Dominique.
Thank you so much, Francisco. Okay, Elise is going to pull up our slides and get ready, and we are co-presenting. I'm actually at the IHI Patient Safety Congress in San Diego, and Elise is in the Bay Area. Okay, so good afternoon, everyone. It is right now afternoon. Today, my colleague Elise and I will discuss how we took part of a journey of efficiency, patient and team member satisfaction, all during a global pandemic. So we hope you learn from our takeaways and perhaps can take some key points into your next process improvement initiative. We can go to the next slide. Thank you.
And Dom, am I sharing the right view? Great.
Yeah, you look good. Thank you. All right. So as Francisco mentioned, my name is Dominique Watt, and I worked in the healthcare industry since 2007 when I became a nurse in New York in the cardiothoracic ICU. And I got quickly tired of the cold winters in New York City, and I came to California as a travel nurse, where I joined Stanford Healthcare in 2010. I realized that I never wanted to leave this organization, as I was quickly drawn to the collaboration between team members and the autonomy that we had to practice. I became a permanent staff member and grew into leadership roles as the years progressed. And I've really enjoyed my time in the interventional platform, in patient care at the unit level workflows, and now hopefully system-wide efforts. One of the things that keeps me at Stanford as an engaged team member is the psychological safety that I have felt on the team with various leaders. And it's probably the reason why I've stayed here, even though I live across the country, from most of my family and my friends. When I am not at work, I do enjoy spending time with my boys, here's pictures of us, and our dogs, and it's either usually watching sports or traveling whenever I can. And I'm really excited to share our story of mostly a learning journey with you here today. And I'll kick it off to Elise.
Thanks, Dom. As Francisco mentioned, I'm Elise Scoggins. I'm the Senior Director of Strategic Programs and Operational Planning for the Interventional Platform, Imaging and Pharmacy. I will make one point of correction. I appreciate the extra degree that I was given by Francisco, but I am not a doctor. So just to make that correction, I oversee our embedded performance improvement consultants for these areas and the program management team. I joined Stanford, as Francisco mentioned, in 2017 in the Facility Services and Planning Department, and then moved over to join Interventional Platform in March of 2019 to assist with the opening of 500P. In 2020, Interventional Platform post 500P really started its performance improvement journey. And in 21, as part of that journey, I actually received my Lean Six Sigma Black Belt and haven't looked back since. And similar to Dom, I left the cold winters behind for the West Coast in California.
Okay, and as we go through these things, please feel free to ask us questions at the end, because I realize we might be using terms that are specific to the interventional platform. We will definitely do our best to explain them. However, Elise and I probably have a narrow focus that we might not be aware of because we've been in the work for so many years. So if something doesn't make sense, feel free to throw it into the chat or ask us a question at the end. We love questions. So we're going to go over our process improvement project that started back in 2020. And as I've reflected during this process of reviewing the process, I realized, wow, we really did this during the global pandemic. Something else that we're really proud of is it still has amazing sustainability and efforts today with the incredible leadership team led by Ann Plum. So what we did was we implemented multiple quality improvement interventions related to delays to first start in OR cases, and they were significantly reduced. We're going to talk about how they improved from 36.7% to 52.7%. What this means is we saved approximately 55.63 hours across over cases, and this resulted in approximately of a 3-month savings of over $120,000 and a yearly savings of just under $500,000. However, I cannot underestimate and just talk about the qualitative impact that this had on wellness, staff, surgeons, as well as the patient experience, which we're going to talk about, with just keeping to the schedule. We can go to the next slide. So why is this all important? So I want to imagine, and maybe you've had this experience before, I've had this experience before at Stanford, but imagine if you were coming in for surgery and you're expected to leave later that morning. Let's say you and your significant other took off for you to have this elective but needed surgery, and you made childcare arrangements with your in-laws ahead of time. You woke up early to be at the hospital at 5:30 a.m. because that is the time we do expect our patients to be here. Not eaten or drank anything since dinner last night. That personally really gets me going because I need to have my coffee in the morning if you want me to function on any degree. So while your significant other is enjoying some Zoom coffee in the waiting room, your stomach is growling in the pre-op area as you wait patiently. The pre-op nurse tells you that the room is delayed and you will be going to the OR a bit late, but there is nothing to worry about. So you continue to wait patiently. You do finally get to go in, your case goes as planned, and you're in recovery. So everything does go well. But unfortunately, because of the delay, you and your significant other are a bit late getting out of the hospital, and you hit that Bay Area rush hour traffic that we all love. You get home much later than expected. Your plans for a restful evening go out the window because you need to now go back into responsible parent mode, and the hectic life routine resumes. So I do want to admit that this is a minor inconvenience. You are lucky that you have a support system around you to be flexible. Not all of our patients have the same system available, and either way, we in the interventional platform need to consider the impact of our delays to our patients and our team members, as this deviation could be prevented. And I can share with you personally, as a formal leader in the peri-anesthesia region, we were often the first interaction with patients offering service recovery when delays or cancellations occurred, and it was never an ideal situation or conversation. So as a leader, it could also mean trying to find your own staff to stay later in their shift to help with later cases. Delays in the OR and first case start times do lead to higher costs, team frustration, and patient care delays. So we adopted several strategies with an aim to improve these start times. We can go to the next slide. So to explain the system a bit more, this is the high-level workflow for first case starts in the interventional platform. There is some parallel processing occurring in the pre-op area where the patient is, and the operating room where they prepare for the environment for the patient. So the pre-op area nurse goes through their assessment and their documentation to ensure appropriate safety steps with the universal protocol and communicates to the rest of the team when the patient is ready for surgery with a go sticker in the electronic health record. This is kind of like a boarding pass for an airplane. So I'm going to actually fly home tonight. I have my boarding pass on my phone for Southwest, and it means I am ready for travel. The OR staff, then they come home, or I'm going to come home, sorry. Then the OR staff goes to pre-op to pick up the patient when the environment is ready. So when the room is ready, they're going to go to pre-op to pick up the patient and bring the patient into the operating room. We can go to the next slide. Just to give you a sense of all of the action happening on the Palo Alto campus, the interventional platform, it includes 3 buildings with operating rooms. And the type of cases and services have really evolved over the years. So for those of you who were here back in 2020, remember in November of 2019, all of our life problems were going to be solved because we had 500P open. Little did we know that we were going to have the global pandemic and real capacity constraints. But even before that happened, we noticed some significant inefficiencies that we had to overcome with the opening of 500P. So all of this was happening, and that's when we put our heads together and thought of how can we improve our inefficiencies. And I will kick it off to Elise.
Thanks, Dom. So we started by assembling a multidisciplinary team that included representation from nursing, physicians, leadership or administration, and performance improvement to tackle first case on-time starts. For full transparency, a first case on-time start is defined as being wheels in by 7:15 or 8:15, depending on the day of the week. As Dominique mentioned, the scope of this project were the pre-post or peri-anesthesia units within 300P, 500P, and Lane, also known as the Palo Alto campus. We focused in on that. We knew we had inefficiencies before 500P opened, and as Dom mentioned, 500P really highlighted those inefficiencies, and we knew we needed to tackle everything across all 3 to avoid confusion amongst staff and providers for workflow differences. The group started with the biggest opportunity, which was getting Go Sticker applied by 7:10 or 8:10. This is seen at the chart on the right with the red tops of the bar chart as our biggest area of opportunity for lateness. The team settled on 2 data sets. Ultimately, we needed Epic to be our single source of truth. However, we also maintained a smart sheet with additional first case information that didn't include any PHI. I want to fully acknowledge that we maintained redundancies of what was being captured in both Epic as well as Smartsheet. And it was super duplicative on the staff to have to enter information into both Epic and Smartsheet. However, Smartsheet allowed for more flexibility and real-time changes to delay reasons, as I'll talk about in a little bit, and the nimbleness of what we needed to do over these next 4 months with the project team. Ultimately, Smartsheet allowed us to develop real-time dashboards so the nursing teams could review our outcomes during daily huddles to summarize first cases for the day. And so for our project, our time period is we really focused in from December 1st of 2020 through the first quarter of 2021, March 31st of 2021. As the team continued to evaluate first case on-time starts and what was preventing us from getting in the room on time, we needed to understand ultimately where to drill in. At the time, Epic had over 30 delay reasons, which didn't yield meaningful Pareto results for the team. So ultimately, we decided to group delay reasons together into themes to be able to pinpoint the biggest areas of opportunity. As you can see on the chart on the slide, the biggest opportunity was the purple bars, what we called the pre-op process. This included elements of the Go Sticker that Dominique talked about, specifically areas of missing required documentation, surgical marking, and consent and procedure. We then put together a fishbone diagram, really focusing in on that pre-op process that I just showed, that was ultimately preventing for the patients from getting in the room on time. We identified root causes into 6 main domains: communication, documentation, staffing, supplies, materials, and patient. And given our active partnership with the physicians and providers at that time, we ultimately wanted to tackle the documentation element of the fishbone first to be able to make progress quickest with the physicians at the table. And so here's where I'll get into the value that we saw within Smartsheet. So within Epic, we had one delay reason that was called missing required documentation. However, for our purposes, it really included 3 different types of documentation, which would ultimately require different interventions to address. So within missing required documentation, it included consent, H&P, and orders. And so we could not and did not want to change Epic for this project. So we ultimately, as I've mentioned, leveraged Smartsheet to be able to make changes quickly. And the reason we couldn't make changes within Epic at this point is that would require buy-in from all of Interventional Platform, not only from the Palo Alto campus, but from the Tri-Valley campus. So we have since made changes to the delay reasons, but it's a big undertaking that we don't take lightly, and wanted to make sure that we're making changes one time, because ultimately we want to make sure to prevent confusion amongst staff. And I really do want to shout out Dom and her leadership with her team during this time. This was a huge ask to be able to ask the frontline nurses to double document. And we didn't take this lightly, but through her leadership, we really were able to make changes quickly and advocate for this importance of double documentation. As we continued to refine our delay reasons and dig into what was driving our delays in Go Sticker, we started to see at the chart on the slide, the biggest area of opportunity of missing incomplete consent, which is reflected in the blue bar, followed by missing orders and then missing H&P. And examples of where we could be nimble is not only one, just breaking apart the elements of Go Stickers, but we could even get more specific and start to see differences between missing H&P. There's 2 types of H&P, interval and complete. And so we could start to really pinpoint as we were digging in where the process was breaking down or where we were having our biggest barriers through Smartsheet. And you'll hear about the specific interventions in the next slide. So I'll hand it back to Dom.
Yeah, so thank you, Elise. As Elise mentioned, it did take quite a undertaking to work with our frontline clinicians to ask them to double document, but we knew we needed accurate information on delays. The other thing we had going for us was we had a really amazing physician partner, a surgeon who was working with us and wanted to actually spearhead interventions around specifically the MD portion of these root causes. So the first thing that we looked at was orders around IVs, antibiotics. And for those of you who don't know, healthcare acquired infections, they are, or HAIs as we call them, they're a burden to patients and hospitals because 1, they're painful if you've ever had one, but they're also costly. HAIs are part of the safety category in Vizient for our patient safety organization and benchmarking, and that is weighted actually 25% in our Vizient ranking, so they do make a difference. They're one of the costliest HAIs is surgical site infections. As a part of the surgical site infection preventative maintenance bundle, we infuse IV or intravenous antibiotics before the incision is made. So the original workflow had required a lot of human factor dependence. And I think people can figure out the more human factors you have involved, the more room for error. With the surgeon, in the original workflow, it was the surgeon remembering to enter the order beforehand in order for it to be prepared on time. This often caused confusion and delays because then it had to be transcribed in Epic and the people actually, pharmacy, and then the clinician actually pulling the medication. In the new workflow, the stakeholders we worked with were surgery, pharmacy, anesthesiology, and then technology and digital solutions, or TDS, and operations. It was decided to have this automatically added to the pre-op order set. So what this ultimately did was it minimized the dependency on memory, but it still allowed for autonomy because what we allowed for was we made it automatic to opt in. So there was still the option to opt out, but it was the exception instead of the norm. We can go to the next slide. So like Elise said originally, this was a big category and we had to kind of break it down to understand what exactly were those root causes for every single required documentation. Another one of the required documentations for the boarding pass that I originally talked about, or the Go Sticker before the operation, is the informed consent discussion with the patient and their provider. And this involves the procedure or the surgery that they're having done, the risks, the benefits, and the alternatives to having it. So basically, in a nutshell, this means that the patient really understands and agrees with the treatment plan, and that they have had adequate time with their surgeon or proceduralist to go over any questions or concerns beforehand. This needs to be documented in the electronic health record as the primary layer of evidence, confirming that it is present before the patient goes to the OR on the day of surgery. One of the top reasons for delays was that the documentation could be found in several places in the electronic health record when it was entered by the proceduralist. So this just took time as the nurse would look for it on the day of surgery. We worked together with our amazing physician partner to create an epic dot phrase, which allowed for proceduralists to use this dot phrase, and it included all the necessary verbiage for informed consent discussion. No matter where they put it in the EHR, if you just Google search, or not Google search, but if you search in Epic, MD dot phrase, MD informed consent, it would show you where it came from in the EHR. And I'm using the analogy Google because when I go on Google and I say, you know, what does blah, blah, blah mean, it will show me all the search engines. So it was a similar analogy that we used. It was easily searchable by frontline staff. And this was a win for us. We can go to the next slide. Okay. Another required documentation before surgery is the patient needs an updated history and physical within 24 hours of the procedure and a complete one within 30 days. The history and physical is a requirement by the medical bylaws and the physician's review of systems. It shows that basically they assess the patient before surgery. Sometimes this was done inconsistently and not properly linked to the current surgery, which would cause some confusion for the pre-op staff that resulted in delays. So our team, again with the physician provider kind of spearheading this from their perspective, developed a template in the MD Navigator to show the best way to link this in order to prevent them from being delayed on the day of surgery. I'll turn it back over to Elise.
Thanks, Dom. So you've heard now about what we did. We did show you at the very beginning kind of how we did. So this will be a test for those who remember. But as we look after January, we had our baseline of December. In January 2021, we implemented our Go Sticker interventions. And then ultimately we saw improvements across all three areas, with the biggest improvement at 500p seeing a 13-point increase in on-time first case starts. In the 2 months post-intervention, we continued to see that uptick of our patients getting into the room wheels in on time, with 500p still on the biggest trajectory for an increase with an overall point gain of 24 points, followed by 300p with 15 points, and then Lane with a 9-point increase for on-time first case starts. And so what does that mean kind of more broadly? So in that 3-month period, the percentage overall of first case on-time starts increased across all 3 locations by 16%, resulting in an estimated cost savings during that 3 months of a little less than $122,000, or if we were to annualize it, around $486,000. And this cost savings is an estimate based off of this survey of all California hospitals, which includes a range of both private and public hospitals. Given that Stanford is a private academic hospital, we've likely underestimated these cost savings pretty significantly, but wanted to be conservative in what was being reported. Overall, the time saved by the OR suite varied. We saw more minutes being saved across 300 and 500 than we did at Lane Surgery Center. And really, this is due to Lane Surgery Center being an outpatient ambulatory site with shorter and less complex cases being performed. In comparison, when we look at 300 and 500, they are handling more complex cases, including cardiothoracic surgery, plastic surgery, vascular surgery, which typically have more complex preoperative processes. And therefore, we're providing those opportunities to continue to reduce the inefficiencies more significantly. We know that this data set is from a few years ago, so we really thought the group would be interested to see how we're doing today. Given the complexities that we highlighted at the beginning as it relates to throughput, whether it's turnover or first case on-time starts, it requires a huge team to ultimately work together seamlessly to get the patient in the room on time. And so a lot of times our improvements within certain projects can be buried overall. So Dominique and I both felt that Ghost Sticker was the most accurate representation to show how we're doing today. And so we have slides for each of our 3 locations that we worked on. And so within 300P, you'll see for our goal of Ghost Sticker of trying to get Ghost Sticker placed by 710 or 810, 70% of the time, 300P is continuing to exceed goal, really being in the mid to upper 70s or low 80s over the past 12 months. Within 500P, we're seeing a little bit more variability, but still, again, really close to either meeting target every single month or being right hovering at target of 70%. And then a little bit more opportunity in lane for our first case on-time starts, hovering around goal, but sometimes not quite meeting it month over month. And really wanted to shout out Ann Wong and her team now as she's taken over as the director of peri anesthesia within these locations for continuing this work month after month and really continuing their PI journey within that department. And so we wanted to end with our lessons learned, as Dominique and I both have gone on our separate but together performance improvement journeys of what really worked well and what we want to consider for next time. So I'll tackle what worked well. As we both highlighted, the multidisciplinary team was crucial. The engagement that we had from Dr. Nazarali and his partnership, we could not have done really any of this work without him, as well as the engagement from a leadership perspective of Dominique, as well as her team. This really helped ensure that we were capturing the problem from multiple points of view to tackle and address. We also, in the partnership of Dr. Nazarali, went on a lot of evening roadshows with different services on the School of Medicine side to gain that buy-in. And here again, this is where Dr. Nazarali's partnership was so crucial for us. He was able to really talk physician to physician around the importance of this work and help with the sell of what we were ultimately trying to do is make everybody's life easier from both the frontline nursing as well as the surgeon and anesthesiologist perspective. And then once again, from a performance improvement perspective, the engagement that we had with operations to, in a sense, double document was so crucial and such a huge value add. I think a lot of us from the performance improvement perspective struggle with data collection, especially when it's manual. And so to have a team that just leans in and says, yeah, we're going to double document, we would not have been able to do half the things without that. And so I'll turn it over to Dom for what we would consider to do differently next time.
Yes, and as Elise mentioned, we had a lot of success with this project, and I think what speaks most to it is the sustained improvement as the leaders have changed, because that thirst and hunger for process improvement has been ingrained in the culture, which is really amazing. We still have some lessons learned, and I definitely want to share that with this group because hopefully you can turn those lessons and apply them to your projects. So we recognize the challenges posed by the interventional platform's broad focus, and it sort of made it difficult to pinpoint specific successes, but also did we need to maybe do tests of change and pilot projects in certain areas instead of just doing a broad focus, kind of broad stroke right away. The opt-in approach for the DOT phrase, the MD informed consent DOT phrase. It was a great tool. It was a great idea. As Elise mentioned, Dr. Nazarali did some really fantastic roadshows with us, and we really appreciated him spearheading it to talk physician to physician. I think now in hindsight, we still have, we recognize that we have lower compliance rates for the DOT phrases. And now as we look at it, we need to work with the people who do use it to understand how it's adding value to their workflow, to hopefully see if more people would opt in, or do we just make it a forced function? That's something that we are kind of discussing right now because it's still a delay reason. The other thing that I want to talk about, and I think many people here can relate to, is the frequent turnover of residents and fellows. It necessitates ongoing education to maintain any intervention effectiveness. And while we did this wonderful, roadshow, we were doing it for several months, I don't know the value and how much that education intervention has been sustained. And that is something that I think as an organization, we can do better. As I mentioned before, the proof of concept with a single service could have streamlined our efforts for not only the dot phrase, but also antibiotic order sets. We could probably optimize that even more, and I know the Surgical Site Infection Task Force is looking at that from an HAI-MGT perspective. While we automated there to be an order, we did not necessarily specify which antibiotic should be chosen, and that can help with optimization and decreasing our numbers of SSIs. So I feel like it was great. We definitely improved efficiency, but now we need to level up and think about how we can improve the quality of care. And these lessons will all guide our future initiatives. And I think we're going to turn it over for questions at this point.
Thank you, Elise and Dominique, for your wonderful work and presentation. And definitely, anybody has any questions, either feel free to unmute or put it in the chat, and then we'll go from there.
Hi, great presentation. I'm particularly interested in how you formatted your road shows. Like, was it presentations, discussions? Was it varied based on audience, etc.?
So I think it was a little bit of both. So we had a standard and set of criteria that we wanted to discuss in terms of the MD consent and standard documents, but it definitely was catered to what we understood would be most important to that particular service. And within our smart sheet, we were able to track, we didn't put any PHI obviously in the smart sheet, but we were able to track room and surgeon so that we could kind of start to see where there's certain things that a particular service didn't do as well. But so we try to do a standard with a little customization. I don't know, Dom, if you have anything else to add.
Yeah, like Elise mentioned, we had a standard deck that we, it was our roadshow deck of this is what we want to hit on based on our delay documentation from Smartsheet. And basically the reason why we were there today. And then Dr. Narihina was going to ask the providers, based on the group going to, we would sometimes customize that delay data to that service, kind of give an IP, an interventional platform overview, but then narrow it down to the service line. But the TLDR was the same. These are the delay reasons, help us help you. This is what we need from you. And these are the tools we've already developed to help you with that. And then let him kind of do most of the talking on what else do you need to get there. Does that answer your question?
Right, there's another question in the chat. What time are patients told to arrive in pre-op?
I'm going to actually defer to Etta, who's the current patient care manager, in case it has changed. It's somewhere around the 5 o'clock hour, but I don't know if, because that was 5 years ago. So I want to be respectful of current leadership and see if that has changed. Thank you, Etta.
If anybody else has questions, what's on the screen or yeah, go ahead. Oh, you're muted. We can't hear you.
Talking to myself as usual. Sorry about that.
Yep,
Thanks.
there you go.
Associate CMIO at Stanford Health. This is great work. And as you know, this happened. We do this. We keep doing this over and over and over. My questions. I have two questions. One is, at any point, did you do a full value stream map to sort of start to finish and try to push error correction upstream? And in that same vein, at around the same time, we started to implement procedure paths in Epic, which was a checklist to look for all of these elements that fell out, pre-op documentation, consent, orders, et cetera. Has that changed workflows? Has that assisted in keeping our processes as efficient as possible?
Yes, so I can start and then Elise can definitely add. To answer your first question, we did process map a lot more than what we showed you. I think our bookends were specifically chosen though for our patient experience in the peri-anesthesia region, because when we were, and the way our process improvement journey started, it wasn't necessarily the organic way of, hey, I've noticed a problem, let me go throughout this. While we all felt the burden of things that we were feeling on a daily basis, transparently, we were also told by our SVP, you need to fix this problem right now. So me and my team, and that's why I do want to recognize Etta, John, all of the people, and we said, you know what, while we can look further upstream to the clinics and all of that, we know we have enough stuff within our own wheelhouse to fix right now. And that was our bookends of our process map, from patient coming to pre-op, or even maybe the day before from the phone calls to patient leaving PACU. Now, that was the focus of our work right now. I want to also acknowledge the incredible work they are still doing, which it probably the bookends have expanded. Procedure path is being looked at, and it's actually being utilized by the pre-anesthesia clinic, which would be a different team. But for this work, we knew we had enough work to work on internally. We were not at the point yet of looking like, hey, we need to look further upstream impact, because we knew we had enough standardization to improve and enough inefficiencies within our own work.
Just to add on what Dom said, in terms of kind of how this started, we actually broke what we now call interventional platform throughput into kind of two different work streams. There was the first case on-time starts that Dominique at the time and team really focused in on from a peri-anesthesia perspective. And then there was turnover that they were obviously impacted by, but more OR and procedural areas focused on the kind of subsequent to follow cases. We've since kind of merged things together for throughput, but we did do value stream mappings for both processes and workflows. We just wanted to show something that was a little bit easier to digest in this setting.
Thanks.
Can I ask too, so you brought in patients at 5 a.m. for a 7:10 in OR time, was that right?
Yep.
Okay.
So patients arrive, we ask them to arrive at 5 a.m. and then for a wheels in at 7:15. It's what we would consider kind of like a big bang start.
Okay, 7:15, got it, thank you.
I guess that's better than 4 hours for a transatlantic flight, so. Still pretty early.
And then this particular project, I mean, I think every hospital is working on some element of turnover or first case on time starts across the country. For what we shared, it was a 4-month-long project.
Thank you. So I want to share to what Elise is sharing. I will say from an operational perspective, the work never really goes away because it's on our ops plan. So while we had the project, start and end and our efforts, it's still on everyone's minds, because while we focus on first case on-time starts and pre-op, it's still related to throughput. We still have an ongoing effort. And I think that is very important, is how do you build the project and embed it into actual everyday work so you don't just forget about it. And I saw the comments about, unfortunately, we haven't been able to automate the delay documentation. If someone can figure that out, that would be great. But it is more part of the electronic health record. But it is, we have various throughput initiatives now being worked on. Carla, this included all patients coming to our pre-op area. So if they came to the pre-op area, then yes, they were included.
There's another question here. Did this project include pediatric patients who were scheduled in the Stanford Healthcare site?
Yes, that is what I just answered. If they came to our pre-op area, then they were included.
I have another question. I loved your suggestion, or the limitation of how to include fellows and residents who are constantly rotating in these projects and how to keep that education going. Any learnings or recommendations from your experience trying to implement that with these teams?
I think now in hindsight, as we're doing quality improvement work and trying to figure out what's the best organizational structure liaison to work with, utilizing the physician improvement leadership and understanding what mechanisms of communication they have embedded. And we don't have it fully figured out because we're still, and then also knowing as I've gone through like process improvement journey, as Elise has mentioned, that obviously education alone is such a weak intervention. You have to build other things with it. So like I said, while we came up with that informed consent dot phrase, and it's really amazing, were we too gentle in our approach of saying, hey, there's this great idea, but should we have maybe made that as an opt-in option, or maybe automated it so the opt-out was the exception and the opt-in is the norm, sort of like we did with the order set, so that we had the double mechanism of not only education, but more of like a, not force function, but kind of you have to do something here, just relying on the hierarchy of effectiveness of interventions as I've reflected on this over the years. But you don't know what you don't know. But I think we can all do better of maybe not just thinking of education as an intervention. What are we coupling with technology to make sure it's sustained so that a brand new person coming to the organization is not relying on all the things they learn on. And maybe they do learn in their first week of onboarding, but how can you expect an adult learner to actually obtain and comprehend all the information they learned right away?
And I think just to add on to what Dom said, we definitely have not fully solved this or addressed it. I don't even think we have within like our frontline staff of everything that staff are required to learn when they first start, plus their yearly competencies and relearning. So I think we do have an opportunity to really try to figure out how do we take people-dependent processes out of the equation and make it more hard stops and automated. And look at what we're asking our staff to be able to learn and retain on a daily basis as we're making these workflow changes. So I think we continue to have areas all around, opportunities all around in these types of areas.
Any other questions? No? All right. Well, again, thank you, Elise and Dominic. It's a lot of work, especially the cultural changes, which I'm sure was one of many challenges that you had to face. But I think this is something that can be a good lessons learned, especially for other areas that might be having another similar streamlined kind of process challenge as well. So really appreciate all your work. Sam and Selena have any last statements?
Yeah, no, just put an announcement about the Quality Symposium on May 15th. There is a link on the website to submit your posters. Yes, so please submit your posters and join us at the Quality Symposium. Have a good afternoon, everyone.
Take care.